Hi, everyone. My name is Ryan Fredericks. I'm on the Inspire Grand Rounds Committee along with Bram Welch-Warren and Shannon Flood. So thanks for joining us today. I'm just going to kind of go over a few rules that we have first, go over what the plan will be for today, and then we'll go from there. So if you're able to use your camera and show your face, that's great. Please do. If not, we totally understand. Second, if you don't mind putting in your name or next to your name where you're calling in from today or perhaps where you work, that would be great as well. For the presentation, we'll ask that everyone keep their microphones off, and we will have questions available at the end of Amy Flores' presentation. And then also we'll have a small group at the end where you'll be able to talk, but we just want to make sure that you keep your microphones on mute throughout. And any questions throughout, please, you can just put it into the chat. Along the presentation, now, at the end, whenever. And finally, this is a recorded session here today so that other people can enjoy this content afterward. So without further ado, we'll get started. Once again, thanks for joining today for Inspire Grand Rounds. The goals of our Grand Rounds presentations are to support mid-level and mid-career providers and to provide opportunities for networking for our members and highlight physician and non-physician simulation researchers. Next, I'll introduce Amy Flores here in just a minute. Her talk will go for about 40 to 50 minutes or so. We'll have 10 minutes for Q&A afterwards. And then after that, we'll have about 20 to 30 minutes or so small group discussion to continue the conversation from today. So without further ado, Amy Flores, DNP, APRN, CPNP, AC, is a cardiac ICU advanced practice provider and simulation educator at Cincinnati Children's Hospital Medical Center. In Cincinnati, Ohio. She completed her BSN and MSN degrees from Duke University and her DNP from the University of Alabama. She has completed a simulation fellowship at Center for Simulation and Research at CCHMC. In the pediatric cardiac ICU, she's involved in research and quality improvement focused on cardiac arrest prevention and resuscitation. Through her CICU role, she has become an advocate for advanced practice providers functioning to the fullest extent of their role. This includes functioning as the team leader during patient decompensation and cardiac arrest events. Her DNP work focused on validating the Concise assessment of leader management tool in real-life events has contributed to this goal and is part of the situational awareness leadership training course offered to all advanced practice providers at CCHMC. In addition to this focused work, Amy leads or co-leads additional simulations and virtual reality education within the Heart Institute and Division of Advanced Practice Providers at Cincinnati Children's Hospital and Medical Center. And she'll be talking to us today about that COM tool, or the Concise Assessment of Leader Management Tool, evaluation of healthcare provider leadership during pediatric emergencies. And with that, I'll hand it over to Amy Flores. Thanks for joining us today.
Thank you so much for the Inspire team to invite me to share this work. I think that Ryan's introduction did a great overview of kind of how I got interested in this aspect of care. I also want to thank the rest of my study team on this, Dr. Lindsay Nakarni-Shepard, Dr. Erin Calhoun, and a number of others who really helped guide me in this research. So I think that Ryan introduced me pretty thoroughly. So I'm an APP at Cincinnati Children's. My clinical work focuses mainly in the cardiac ICU and sometimes in our acute care cardiology unit, which is our step-down unit. But I do a lot of work with the simulation specifically for APPs, CICU, and Heart Institute employees. And I'm starting to also enter into the VR education and research side of things as well. I'm a nurse practitioner on our CICU team, but also within the HI, we have a robust APP education leadership structure. And I also lead simulation for the PCICS, or Pediatric Cardiac Intensive Care Society, many of their courses, including the Advanced Provider course and our Advanced Provider course, which focuses on both fellows, physicians, APPs, and nurses. So a little overview as to how I got into this. Also, as a side note, I'm an avid FC Cincinnati fan. For those of you in the US and Canada, we're #1 in the MLS right now, so I just couldn't get through without doing that. And I'm also a mom to two great little boys. This is kind of an outdated photo, and my husband Rob as well. So as a little background to how I got into this is my doctorate project. So pediatric in-hospital cardiac arrest is rare, but is common in the area where I practice. There's about 15,000 pediatric cardiac arrest events each year. Most are non-shockable rhythms, but that is an in-hospital cardiac arrest rate of 1.8%. And in the pediatric CICU where I practice, that rate is actually more higher at about 3%. While survival of the cardiac arrest event is high with things like ECMO and additional advanced life support, survival to discharge is really only 30 to 50% in our patient population. We found that improved survival rates are associated with the underlying diagnosis, cause of the event, initial cardiac rhythm, and most importantly, the quality of CPR that's delivered. So when we review the AHA Get With the Guidelines Resuscitation Registry, we found that the time to first dose of epinephrine during a code is strongly associated with ROSC, 24-hour survival, survival to discharge, and survival with favorable neurologic outcomes. And thinking through the chain of survival, we have our prediction, prevention, training, response, and recovery. A lot of our simulation and VR focused education is in this training and response. We hope to improve the training of our providers and then improve our response and then hopefully have better outcomes in recovery. So a bit of background about acute care nurse practitioners. I don't know if everyone on this call works with us or not, but we are extremely prevalent within the institution where I work and particularly in the CICU and other critical care areas as well. So about 26% of all pediatric acute care certified NPs practice in critical care units, which leads for opportunities for us to function as team leaders during emergencies and resuscitation events. Graduate nursing programs offer limited or more likely no training on how to be successful and confident leaders during these emergent events. But over 80% of acute care pediatric nurse practitioners feel that knowledge and skills surrounding emergent and life-threatening situations and initial resuscitation measures are extremely important in our role. So this has been something that I've been extremely passionate about as an NP in the cardiac ICU at Cincinnati Children's. When I first got there, we did not lead any codes. So even if we were the first people in the room, we weren't educated on how to do so. And our attendings quickly took over when they arrived to the room. And in having discussions with my leadership, both APP and physician teams, it was something that we thought would be a great skill for our APPs to continue to develop as our acuity and our patient census increase. So to get a little background, I sent a survey through the Pediatric Cardiac Intensive Care Society. I had 53 APPs and 54 physicians respond, and these were all attending physicians, not fellows or residents. Just over half of APPs had never led a code, and only 28% of APPs had functioned in the team leader role in 1 to 10 code events, and only 21% in greater than 10 events. 94% of all respondents reported that attending physicians typically led codes, and just over half of attendings supported APPs leading codes. Of those APPs who had functioned as a team leader, just over half reported receiving informal training, which they cited as on-the-job training, discussions with a mentor, and simulated patient events. And only 23% of APPs rated their comfort level to function as a team leader as high or very high. We also found that 67% of attending physicians didn't allow APPs to lead codes. They cited perceived knowledge gap, lack of experience, lack of interest, and the need to train fellows as the reasons for why this wasn't happening. Despite this, 50% of these attendings said they would allow APPs to lead codes if a formal training and competency checkoff for this skill existed. And nearly 90% of CICU attendings did support a formal team leadership education, training, and evaluation program. As we know, teaching emergency and code team leadership is a complex skill. It's difficult to teach due to the unpredictability of patient acuity, frequency of code events, variations in experience of resuscitation teams. And we know that improved communication and leadership is associated with improved survival to discharge following a cardiac arrest event. While there are extensive guidelines on resuscitation and teamwork, communication skills aren't standardized at the leadership level. So looking at other team leadership education that existed in the literature, there's a combination of didactic education, simulation, and direct feedback listed. So these are things like crisis resource management, team steps, and then there are several evaluation tools for teamwork and communication, including the team NOTEX and the team. But they're really at the time that we were starting to think about how can we create a course for APPs and have a validated checklist. There really wasn't anything when I first started looking that would support that. And so I'm going to continue to go through the background and then I'll get to kind of what we did find closer to starting the course. So crisis resource management, I think we all know, is adapted from the aviation field. It promotes standardization of communications in order to reduce errors. The communication strategies include closed loop communication, sharing of a mental model, and the use of a checklist. Some other teamwork found that a combination of didactic education, simulation, and direct feedback were most effective. Burden found that teaching crew resource management to residents through simulation taught communication skills better than lecture-based training alone. Greg found that a didactic education on communication and teamwork combined with direct performance feedback improved and maintained leadership behaviors. And Capella found a combination of a 2-hour didactic team steps and simulation resulted in improved leadership, situational awareness, and communication. And so looking through what other tools and checklists existed at the time, we found these the team notex and the team tools. And I'm sure you guys are all familiar with these or have seen them in some capacity. And these really evaluated team performance, with leadership only being one aspect of the team performance, and had pretty broad definitions of what a good team leader was for you to evaluate as part of the team performance. And so in thinking through what I wanted to do for a doctorate project, I knew I wanted to do something in this area of team leadership education, team leadership performance, particularly for the APPs, but would cross to physicians as well. And in talking with some of my APP contacts through the PCICS, I was connected with Dr. Erin Calhoun, who mentioned this tool that Dr. Nakarni Shepherd and her team had been working on, and thought that we could kind of build upon some of their initial validation studies through some experiences at Cincinnati. And so the Concise Assessment Leader Management Tool, or the CALM tool, was designed by Dr. Nakarni Shepherd's team through a review of the literature and expert consensus by experienced physicians. It was divided into 4 main categories that evaluate leaders, including leadership, communication, team management, and medical management. They found it to possess validity and reliability for use as a tool for formative feedback and simulated resuscitation events. So this is the CALM tool. As you can see, we have those 4 giant roles, so leadership, communication, team management, and medication management. Under each of those, there's really specific behaviors that are indicative of positive team leadership. So clearly announcing your role as a leader, maintaining that through the case, and ensuring an appropriate handoff occurs if that leader happens. Is the style appropriate and effective for the situation? From a communication standpoint, is the voice appropriately loud and clear? Do they address people explicitly by name or make eye contact? They reinforce closed loop communication. I'm thinking about teamwork. Do they assign and acknowledge roles? Do they direct the team effectively, balance the workload, engage team members in decision-making, and summarize the case status periodically? We call that a shared mental model at Cincinnati, and I know other institutions use that as well. And then thinking about the medical management for the patient decompensation event, do they prioritize task order, maintain a global view, periodically reassess the patient, state the next steps in patient care, and aware of limitations and seek help as needed? They also have an additional opportunities for medical knowledge and global assessment that raters can provide feedback with the leadership performance if needed. So this team assessed 4 leaders performing 4 simulated emergent scenarios. As you can see, there's a cardiac arrest, a respiratory arrest, an infant seizure, and a septic patient. They had 4 raters, all from within Inspire, and all were Peds Emergency Medicine Fellowship Directors assessing this performance. They were instructed to use the CALM tool, and each rater watched all the videos. So what they found in doing G studies, and I apologize, the bar here is right over my slide, so I got to get it out of the way, is that they performed this person times rater times scenario G study, looking at the estimated variance from each specific facet. So as you'll see, person was the largest contributor to variance, and this is indicating the variation between the team leaders, so their education, their knowledge, their background, and how they manage the patient. The rater was also extremely minimal, being 0, meaning that the raters all rated using the CALM tool, rated the leadership skills the same, and the scenario also had minimal variance. The G study for 4 raters and 4 subjects resulted in an absolute generalizability coefficient, or G coefficient, of 0.8. In addition to that, they did D studies looking at how they could further improve the reliability and validity of the tool. As you can see, the more scenarios and the more reviewers that you have, the better the G coefficient will become. So we hoped to build on this initial CALM tool validation to validate the validity and reliability of the CALM tool as a means for both formative and summative feedback and assessment of team leadership skills during real-life pediatric resuscitation events. So we built upon the simulation validity study and applied it to real life. So as some background, for those of you who are unfamiliar with validation studies, and this was my first one, I worked with Dr. Calhoun and he kind of verbally taught me all of this, but there's recently been a publication preparing and presenting validation studies that if you haven't read and you're interested, I would highly recommend. It really outlines how to present a validation study and ensure that you're publishing it properly. So there's really two frameworks that you can use for a validation study. You can work on Messick's framework, where there's framing the study, a structural focus, and various framework elements. And these kind of all build together to influence Kane's validity. So they have multiple validity arguments, and I'll go through all that as well. So Messick's and Kane's frameworks are very complementary of each other. Messick's is primarily concerned with types of evidence that can be provided to support construct validity, while Kane addresses the overall structure of the intended argument itself. And so also within this publication is a really clear outline of how to publish your validity and reliability studies within SIH or other publications that you would be looking for. And I think that this is really helpful as a tool to frame your publications in this area. So now going more in depth through Kane's validity framework, which is what we chose to use for the second CALM study. So you have a scoring inference, a generalization inference, an extrapolation inference, and an implication inference. So looking at the scoring inference, you have the construct of an assessment tool is evaluated to determine if the individual items being measured translate into a numeric score. So for our study, this was taken care of during the first CALM study when they developed the tool. You have the generalization influence, so how the scores can be generalized to the test setting. You ensure you have an appropriate sampling, and then you do G and D studies at this level. And we did that, Dr. Carney Shepard's team did that within their initial validation study as well. The extrapolation inference is how well does the test apply to the real world? We hope to look at this in our study, and how does the score correlate with clinical practice and outcomes? And lastly, the implication inference. So what can the tool be utilized for to propose its intended purpose? So for our study, our first aim was to effectively argue the validity and reliability of the CALM tool as means of assessing leader performance in real-life resuscitation events using the scoring and generalization inferences of Kane's model of validity. We hypothesized that the CALM tool would show a strong G coefficient with high subject and low rater and case variances as assessed by G and D studies. We also looked at, our second aim was to effectively argue the validity and reliability of the CALM tool as a means of assessing leader performance in real-life resuscitation events using the extrapolation inference of Kane's framework and validity. We hypothesized that code team leaders with higher CALM scores will have a shorter time to first dose of epinephrine and time to first defibrillation than those team leaders with low CALM scores in cases of cardiac arrest. And we hypothesized that code team leaders with higher CALM scores would have a shorter time to fluid resuscitation and first antibiotic administration than those team leaders with lower CALM scores as assessed in cases of septic shock. So when thinking through the design of this study, we used real life recordings of real patient events. The ED at Cincinnati Children's has continuous 24-hour recording within their trauma suites. And so we worked with their team to kind of determine what would be the best scenarios to use and thinking through that we could capture one team leader running multiple scenarios for the purposes of our study. So septic shock is one of the leading causes of pediatric mortality worldwide. Guidelines recommend rapid administration of antibiotics and fluids in septic patients. With each hour in delay, an administration is associated with increased mortality and end organ damage. And we know that strong team leadership is imperative to ensure rapid and effective response to the resuscitation of patients with cardiac arrest and/or septic shock. So looking further at our methods, we use video recordings from the emergency department at Cincinnati Children's. The inclusion criteria were they were admitted to our shock trauma suites here at Cincinnati, and the team leader had to be evaluated during 2 separate resuscitation events, 1 cardiac arrest and 1 septic shock. Exclusion criteria included continuous video recording didn't exist or at the start of the resuscitation event, any code event lasting less than 1 minute, as we felt we couldn't adequately assess leadership performance in less than 1 minute. Any subject who had taken part in a PALS or ACLS renewal course or other course focused on crisis leadership training between their video recorded sessions were excluded. And septic shock patients who did not receive the majority of their treatment in the trauma base were excluded. Oftentimes, these patients are admitted into a general ED room, and then as their status declines, they're moved to those shock trauma suites. And then if by chance there was a resuscitation scenario led by a registered nurse rather than a physician leader, that was excluded as well, although we did not have any of these. So, and then the CALM tool was completed for each event. So we had 3 separate reviewers, myself as an experienced CICU APRN. We had the ED medical resuscitation coordinator, who's a master's prepared nurse. And then we also had a medical student who had been working with the ED at the time of the study. We tracked time to critical events. In cardiac arrest, we look at time to first dose of epi and or the first defibrillation, depending on the PALS or ACLS algorithm that was needed. And in sepsis, we looked at time to fluid resuscitation, defined as that first 20 per kilo fluid bolus, and time to antibiotic administration. For reliability, we looked at GWETS, AC2, the interclass correlation, and for validity, we looked at G and D studies. We tracked total CALM scores, and then, as I mentioned, time to critical events. So over the course of time of our study, which was somewhat limited to make sure that my doctorate project stayed on track, we were able to capture 9 team leaders, each leading 1 cardiac arrest and 1 septic shock resuscitation in our trauma bay, which led to 18 videos that could be reviewed by the 3 reviewers. The CALM scores out of 62 were calculated for each scenario by each reviewer. We found an inter-rater reliability of 0.3 with a 95% confidence interval of 0 to 0.67. Just like the previous CALM study, we did a fully cross person times scenario times rater design with 3 raters, 9 subjects, and 2 resuscitation types. And then we evaluated individual factor and factor interactions related to score variance in the CALM scores. So what we found was similarly, we had 26%, and as you might remember from the other one, there was about a 30% person, meaning team leader variance. We did have a 20% rater variance in this one, and we'll go through a little bit about why we think that, and we think that that also contributed to some of our unknown error. What we found with our 3 raters in 2 cases was a G coefficient of 0.68, which is sufficient for formative feedback, but not summative feedback. And in order to reach a G level of 0.8 or higher needed for formative feedback or summative feedback, meaning pass-fail, we would have to have done 4 raters in 4 cases, which interestingly enough is similar to the initial CALM study that they were able to choose. So when trying to look at this rater error and unknown error, we kind of broke down our data a little bit. I kind of hypothesized, just as the person inputting the data, that perhaps there was some differences between how we as reviewers assessed the performance of the leaders. And so that kind of led us to look at some interclass correlations between raters. So reviewer 1 for this information was me. Reviewer 2 was our ED medical resuscitation coordinator, which was an extremely experienced nurse. Combined, we have over 30 years of experience in the CICU and the emergency department with frequent exposures to patient decompensation event and code events. And our 3rd reviewer was a medical student who, obviously, given her place in training, had really just had not as many opportunities to experience, whether observation or direct experience, these types of events. And so what we found is when we removed reviewer 3, we actually significantly improved our interclass correlations. And what we hypothesized this happened was the medical student was very black and white by using the CALM tool. So when it said things like, did the team leader assign roles? We hypothesized that she was looking for that verbal assigning of roles, a verbal that it happened. We hypothesized that when myself and the other experienced nurse medical resuscitation coordinator, we were able to see the team leader doing that, ensuring that those roles were adequately filled, and when they weren't filling in those roles. And so we kind of hypothesized that the med student used it more as like a behavioral checklist, whereas we used our experience in being in these events to see how the team leader actually accomplished some of these tasks. And I think that this is something that future validation studies of this tool will have to investigate a bit more. We also found a statistically significant correlation between CALM scores and time to first dose of epi during our cardiac arrest events. Our team leaders with higher CALM scores, those teams got epi into the patients much faster than those with lower scores. We didn't find any correlation in the septic shock cases with CALM scores in either of our time to fluid bolus administration and time to antibiotic administration. And we think that has to do with the protocolized nature of how we treat septic shock patients at Cincinnati, and I'm sure at other institutions. We have a protocol and an epic order set that releases everything at one time. The fluid boluses are given rapidly as soon as shock is identified and can be initiated by our nurses in the trauma bay. And the time to antibiotic administration is really dependent on the pharmacy validation and getting that released to the emergency department. So we didn't find anything with the septic shock. So in reviewing our results further and using Kane's validity framework, the scoring inference was previously supported during the Nicarni CALM study. The generalization inference, we did previously show that this possessed validity for simulated scenarios in that study as well. And in our present study, the G study as designed, the reliability of the instrument is acceptable for formative feedback, but is not optimal for summative feedback. And our D studies suggest that this could be optimized, assessing 4 liters in 4 scenarios, similarly to that initial study. Looking at the extrapolation inference, or how does this apply to the real world, we found that inverse correlation between the CALM score and the time to epi administration, but we did not find a statistically significant correlation in the septic shock patients. Further validation studies of the CALM tool for use in real life scenarios and other patient decompensation events are kind of the next steps that I have in mind for this. We do use the CALM tool for formative feedback in a simulation course here at Cincinnati that we've started offering. So we have a simulation course called Situational Awareness Leadership Training, or SALT. We offer it to all APPs at Cincinnati Children's and have been doing it for about 1.5 years now. It's focused specifically on these leadership training skills for our APPs, both in our critical care areas and our non-critical care areas, as resident work hour restrictions are getting restricted and the APPs continue to build within all the areas of our hospital. This is something we've identified as a need throughout the APP and providers throughout the hospital as an opportunity for additional education. We use it pretty informally now. We kind of fill it out as each team leader performs a simulated scenario. We have 4 team leaders going through 4 patient decompensation events and kind of review it very briefly as some feedback for them to use. We hope to further use this. I think we can look at other types of arrest events in different patient areas, looking at additional acute patient decompensation. And one idea that we have talked about using this for is having our PICU APPs specifically attending our non-critical care situational awareness leadership training course. They're going to be attending and arrive as our rapid response team and take over the team leadership from the non-critical care APP. And we hope to look at their real performance and their real rapid responses, because our PICU APPs are the primary respondent for the rapid response at our institution. We have a team called the Critical Care Outreach Team that is PICU nurses and a small team of PICU nurses and RTs who are always at those. And so that we're hoping we can utilize them to assess leadership performance of our APPs during our real life rapid responses, using the CALM tool, tracking that through the situational awareness leadership training, and then also assessing them during their real performance following the SALT course as well. And so we're kind of in the steps of building that. I couldn't find anything else in the literature that anyone had used or further validated the CALM study, but if anyone knows, that would be fine. I'd really be interesting to hear. I just couldn't find anything when I looked in the past couple of weeks. So in conclusion, the study provides some evidence to support reliability and validity of the COM tool for leadership evaluation for formative feedback following real-life pediatric resuscitation events. In its current format, we recommend that the tool for raters with clinical experience in resuscitation events and team leaderships to use for formative assessments and evaluation. The COM tool can be utilized to formatively assess critical care and emergency medicine providers who are new to the team leader role. And further work is needed to optimize the performance of the COM tool. And as I mentioned, future studies are warranted. I also wanted to take some time to acknowledge all the mentorship and collaboration I had on this project. Lindsay Justice is a CICMP with me, and she was my doctorate mentor. Mary Frey and Dr. Ben Carey from the CCHMC Emergency Department. Dr. Angela Collins-Yoder, who was my mentor through the University of Alabama Capstone College of Nursing. Dr. Erin Calhoun, Dr. Lindsay Nakarni Shepard, and David Kessler, who started this COM tool as their initial thing and worked with me on an iteration of the study, and Sarah Constrad, who was the med student at this time. I think she's probably a full-blown physician now as well. And my references.
Wonderful. Thanks, Amy, for sharing that. That was great overview of kind of the COM tool and your interface with it and trying to provide some validity evidence for it, which is great. I have a lot of questions of my own. Personally, I've never used the COM tool. I know, shocking, but I do want to open up to the floor for anyone else to either unmute yourself and ask any questions that you have, or feel free to open up some questions in the chat. We have plenty of time here. We'll do this for about 10 or so minutes before breaking up into small groups and talking further about use of tools, validity evidence, etc. So please, if anyone wants to ask a question, you can either raise your hand or unmute yourself and go from there. All right, looks like Casey, you have your hand raised. Please ask your question.
Thank you. I don't know how to verbalize how to type this to put it in the chat. I'm curious about the logistics of your video. And so I'm wondering, and maybe I missed this, but how did you flag video and how were you able to get snapshot of video to review?
So at the emergency department at Cincinnati Children's, at the time that we did this study, they had a 4-bay trauma bay or 3-bay trauma bay. As part of their ongoing quality improvement and education, in the resuscitation bay, they have video cameras in each bed space. And so there's actually 2 different cameras looking at the team, and then continuous recording of the telemonitor. And so that is just standard of care in the ED. When the parents sign consent, there is verbiage in that they sign saying they know they're being video recorded. I don't know how many parents actually read that, but that is part of the ED's ongoing quality improvement, education, and event review. And so I actually don't work in the emergency department, so I worked extremely closely with our medical resuscitation coordinator, Mary Frey. Basically, anytime someone comes into the trauma bay, they record the indication for why they were there, the physician that is leading the emergency. And so she actually had this database of when I said I wanted full resuscitation, so cardiac arrest events and these septic shock events, she already had those coded by who was the team leader from a physician standpoint and what type of scenario it was. We actually looked at adding in like respiratory failure and intubations as well, but we were struggling to get enough of those. And so that's why we went with 2 scenarios and not 3. And so they have this system where she has access to all the recordings through the IRB. They granted me access to review these. And so me and the other 2 people just reviewed our specific videos. And so every time a pair existed, basically one physician had done both, she released them to us and we reviewed them kind of as we got them. I don't know if I answered your question thoroughly enough. If you want more information on the video,
You did. I was just thinking
certainly can send
24
it.
hours of video. No, that's amazing.
No, they like
really
her
incredible.
main role is to manage all that and manage the education. So she has like a full library of everything. The videos do expire after a certain period of time. I can't remember if it's 3 months or 6 months to protect patients, obviously. But they've been really great for the emergency department to use for QI, education, event reviews, and feedback for trainees.
Great. It looks like Jill Posner had her hand up next.
Hi, everyone. Thanks so much. This was really helpful to hear about the CALM tool from the from the people who have studied it. I have two questions. One is, has the tool been used for self-assessment? So can the leader themselves, can they assess themselves using the tool? Has any work been done in that? And my second question is sort of related to the discriminatory ability of the tool. I would think that attendings, for example, who are pretty well trained and experienced would be kind of far out to the right side of the score, get higher scores. And is there enough ability of the tool to discriminate among kind of I don't know if it's level of experience or level of performance, I guess it would be, or is everybody kind of out at the high end of the score when they're in kind of a more experienced level of training?
So I think that it really depends, to answer your second question, on experience. And so I actually, all 9 of the videos we reviewed were attendings, and I am completely blinded to the attendings. Like, I knew their last name, but I don't work with them. So I had no preconceived notions about their ability to lead a code or manage a septic patient. And there was significant variation across the 9 attendings in their ability to be in that trauma bay and function in that role. And in talking with some of the ED leadership, the attendings who kind of lead in the ED, I don't think that was a surprising finding. I think that they definitely have some attendings who are more comfortable in the trauma bay role, and those who probably prefer the non-trauma bay thing. So I did see variation despite all the attendings, but I didn't correlate that with their experience at all. So I can't comment on that. And I can't remember your first question because I got very sidetracked with the second
Sorry.
question.
No, thanks for the answer to the second question. The first question is, has there been any use of the CALM tool for leader self-assessment?
I'm not aware of any. I think it's a really interesting idea, and it could be interesting to compare that to an objective measurement from an experienced person and seeing how those correlate. I will say that in doing these situational awareness leadership classes with the APPs at Cincinnati that purely focus on the team leadership side of things, my guess is that the APPs that I've seen would probably rank themselves lower than I would rank them, because when we do like traditional SIM debriefing and ask them what they think they did well and what they think they didn't do well, the individuals are much harder on themselves than myself as the facilitator or the other participants are on them. And generally the feedback that is given and like that we do a combination of didactic education and then 4 simulated patient decompensation events. And the didactic education really focuses a long time aside those like CALM checks. And we have found that they are much harder on themselves. So it would be an interesting study to do to see how people rate themselves versus how others would rate them.
Thank you.
Great. Next, I'm going to read a question from a chat, and then BJ, I'll get to you next. So Nathan Sundgren asked, it kind of along the same lines. What is your gut level experience with the CALM tool? Does the score seem to, in fact, correlate with a good team lead? It really seems like your real clinical event review validates that it would be true. Does it continue to seem to hold true when you use it in simulation scenarios, fellow versus resident versus attending CALM scores? Or for your instance, if you use it for the PCICS course, does a CALM tool correlate with what you think is a good leader? Do they tend to score better when you're using it for teaching courses?
I do think it does, because I think those things that make someone a good leader are these. I actually think that the CALM tool outlines it really nicely, that Dr. Nakarni Shepherd and her team created, because it's those little things like standing at the foot of the bed, ensuring that you verbalize that you're the team leader, ensuring that, like, I think we can all think of times when I'm going to be mean and use 2 attendees as an example, but 2 attendees come in and they both kind of want to lead the code, and then you don't really know who to listen to. And so I honestly, my work into really deep diving into this has really changed how we run our team safety simulations for the CICU and how we educate our providers in addition to our providers. But we also have kind of built this into our CICU fellow bootcamp. And then the attendees have kind of picked up on all of the things that we have incorporated into the fellow and APP training in our unit. And so now it's much more clear who's leading the code. The NPs are much better about, like standing at the foot of the bed. We all used to be nurses, so we want to be up in the action. And so I have seen it clinically within my practice area, and just assessing through the SALT course. Those little things that are on there are things that no one really ever points out to physicians, APPs, as like things like clearly stating who you are, where you're standing, making sure you share your mental model. And even the strategies as simple of like, when's a good time to share your mental model during a code event, during a patient decompensation. So those little nuances in the CALM tool really add up to all the things that make a good team leader. So if someone doesn't announce their role and isn't sure, they're thinking about medical management, but they're maybe not managing the team as well as they can, you can see variations for sure. And I do think it correlates.
Thank you. Vijay, you're next.
Yeah. Hi, Amy. Thank you for sharing your excellent work. I have two, maybe three questions. The first question is, did you have any challenges taking the consent? Did anybody refuse to consent to assess these videos? The second question is, did you take any feedback from these assessors to say how did they feel to be assessed? The third one, whether anybody used, I could get that you sort of discussed your experience in your unit or institute. Was there any data using this tool before and after leadership training to show that improvement, either in simulated environment or the real environment?
All right, so for consent, the ED physicians that I assessed didn't know it was happening. It's just part of their standard of care. So they know that these video recordings occur and that they're going, like, different aspects of team performance and clinical performance are going to be used for research studies. So I didn't have to consent them. Okay. I mean, I did, but they already, like, it's already part of their employment.
Implied.
Yes. And then for the SALT course, we do it very informally right now. Like, we just kind of fill it out and like slide it to them, like, let us know if you have any questions, because I didn't want people to feel like we were like intentionally evaluating them. It was more just for them to reflect on their experience. In terms of looking at pre and post leadership training, that's my next step. I have this very grandiose plan to try to look at all the APPs in the critical care units, like in a real patient scenario, then send them through the critical care SALT class, and then do in a post scenario. But there's 3 critical care units. There's combined through all the 3 critical care units in my institution, there's like 120 APPs. And so we had concern of having like potentially 120, maybe even times 3 different people using the CALM tool. And so that's why we kind of are thinking we're going to just focus on our PICU APPs. There's about 12 of them, and they go to all of our rapid responses. And so we think that we can probably capture that. And that critical care outreach team that I mentioned is 1 nurse and 1 RT on every shift. And it's a group of like 10 of each of them who that's their main like role. And so we figured we could introduce them to the CALM tool, have a standard group of people that was evaluating. We were trying to think about how to do it in a way that made the most sense from a research standpoint, and make sure that we weren't like adding all this variance and raters that we didn't need to. So I think that's going to be our next step. So we'll capture them in a real patient decompensation scenario through that MRT and see their leadership in that. Then they'll send them to our SALT training class, which they'll be essentially functioning in the same role. There'll be a non-critical care APPs, like starting the emergency, calling our rapid response, and then the SALT or the PICU APP will respond. So they'll get training, and they'll get 4 opportunities to function in a simulated environment as a team leader, and then hope to capture another event after the team leader training. So that's my next step in the process.
Thank you. All the best. Maybe next year, grand round, you'll be presenting. I'll stop it there.
Amy, just curious, going off what you just said, are you going to not offer the SALT course to some individuals as a control over time when you do that?
I hadn't thought about that. It's a really good question. I think that we may capture it anyways, because if we really try to get the critical care outreach team nurse and RT to evaluate every rapid response performance by a PICU APP, in order, like, that's, I think, would be the easiest way to honestly do it. We'll capture many leadership opportunities. So some of the APPs, like, we may catch one APP like do 2 rapid responses with no leadership training, and, you know, maybe their thing stays the same. And so I think that we'll get a lot of data, and then we can look at, I think having a control group of 6 and an intervention group of 6 won't be super strong, but we can almost capture the lack of leadership training within each individual plus going through over time is my thought process.
Yeah, I mean, or potentially if you have, you say everyone gets it, but you know, you break up the SALT training into 2 different groups. You know, some people get it at month 3 and some people get it at month 6, and compare the 6-month, you know, the people who got it early versus people who didn't get it, you know, would be a potential way. I mean, like you said, it's a small sample size, but just
And
interesting.
right now, the SALT course is offered twice a month, every month. And so we will have the PICU APPs just kind of sign up one at a time. And so that's certainly something we can see, like the PICU APP who took it month will actually be able to see like over time kind of how it changes.
Cool. Bram, do you want me to read your question so you can save your voice?
Thank you.
Okay. All right. So Bram was asking, he's trying to save his voice for another lecture coming up here for him. But Amy, any advice for those doing some video review studies about sorting out what actions of the team are directly attributable versus not attributable to the team leader? In prior studies using Reed Stone et al. With the STAT tool and Grant et al. With the RTLE resident team leader evaluation tool, this was one of the places where we sometimes wanted to pull our hair out a bit.
Yeah, and I think that's hard. And I think that's where the variation between raters came into play, right? So I think anyone who has been clinically in lots of emergent events can think of things that went well and think of things that didn't go well, and like situations that do that. Obviously, it's not all up to the team leader. But I think that when you're a team leader and things aren't going well, you can see as a team leader, like, you know, if a role is missing. I mean, I was in a code on our acute care cardiology unit this past weekend, unfortunately, and they've been really pressing in their team safety situation, like code roles being filled. And so that's gotten substantially better, but I noticed I wasn't even actually team leader in this situation. The other APP stepped into that role. I noticed very quickly that was missing. And so I kind of shifted into that. But as the team leader, if no one had been there, it certainly is your job to ensure that someone gets there. And so I think a lot of it, and I agree completely, is just experience. And I think that's why we saw that rater variability. So like, I can almost see someone like scanning the room to make sure that all of these things are being done, that the tasks are being completed. Like you can almost like envision like how they're talking and what their body language is, what they're doing. But it is also very subjective, right? So like I would say, sure, they've assigned all the roles, but is that just because the team already had pre-assigned roles and they arrived and they just did them? Or is it because the leader assigned them? That one's like, oh, that one is one of the more gray ones to me. And so my thought process when using this is like, if they weren't all filled, did they do that? Do you see that they're like, okay, we have a defibrillator, we have a CPR coach, we have someone at the head of bed, those sorts of things. But it is kind of nebulous. And I think that's where I think actually doing a study kind of like we talked about at the beginning of this Q&A, looking at like looking at all the different ways people use the tool would be really helpful.
Yeah, I was wondering kind of along the same lines. So I'm definitely not an expert in validity by any sense. I made one tool that was not related to simulation. I'm not David Kessler, Aaron Calhoun, Mark Adler, but when we did a tool, we used retrospective data to look at the Cohen's Kappa score for inter-rater reliability. And we trained each other and met in groups so that the raters became consistent, so that moving forward, when you have some subjective tool, you have some guidance amongst your group moving forward for how do you handle this certain situation. Was there any training on the COM tool amongst the 3 reviewers for this study to look at, retrospective data so that you would have, the medical student can understand what your experience maybe brings to it and why you would rate a certain situation a certain way on the tool to kind of improve your scores a little bit before doing the study?
Yes, we did. We kind of oscillated back and forth on how to do it because in the initial COM study, they talked about that the goal of creating this was a tool that anyone could use with pretty minimal education. And that was one of the goals of developing this. And I think that the caveat to that we learned is anyone with clinical experience in patient decompensation events is probably potentially the asterisk that needs to go behind it. But we do need to do further studies. And I do think it's very straightforward for those of us who work in this area, but I think for people who are a little bit set back from that, or, you know, don't have as much experience, it's definitely not. We did create kind of a data dictionary of what each line of the COM tool, like kind of examples and what was expected. And the three of us sat down and looked at several videos together, and then like did the rating, and those actually correlated pretty well. But then we saw these practice change, like we obviously saw this variation during the other events. And so we tried to do some to control for it, but I think where I saw, like, I would rate someone like a 3 out of 4 on like roles were filled, and then the med student would rate it like 0 out of 4 because it wasn't verbalized, or I noticed it was like happening, and then there was like one minor thing that I perceived could be better, and so did the ED resuscitation coordinator, but then it was like a never for the med student. But I think I still struggle with it because we want it to be this very straightforward tool. And so I think what our secondary study is, it gave you a little bit more guidelines of the anyone can use it asterisks of what those anyone people are.
Thank you. Does anyone else have any other questions, either to put in the chat, or if you want to unmute yourself or ask, or raise your hand and I can call on you, whatever
I
you
just
want.
have to say what a dream come true this presentation is, Amy. You did such an incredible job with this, but it really also tells the story of Inspire. And so thanks to Ryan and Bram for sort of organizing this grand rounds, because I mean, you did a great job presenting, Amy, and it barely touches the tip of the iceberg of all the different little Inspire projects and pieces, from Cincinnati Video Review and Viper to sort of, you know, Aaron's validation work. And it's just so nice to see projects grow from what was really like a formative educational tool off the shelf to now we're looking at, you know, approaching that threshold for summative assessment, and again, looking at growing into the clinical environment, which I think is the goal really of banding together.
Do you know of anyone else working on the COM tool, Dr. Kessler? I really
I redirect everyone to Lindsay, as
Okay.
is my duty. And
Yes.
you know, but I think that Jill Posner, who's on the call, was talking about doing a project. I other than you, I haven't heard as much happening yet in the clinical environment. And I think, you know, COM or not COM, I think this is a space for Inspire to continue to grow, especially with so many people starting to have video databases and sort of struggle with that translation of simulation to the clinical environment. I, for one, am really enthralled by the potential of AI to take some of these tools and some of this validation work that you're doing and start to develop some more objective measures. Who just got her hand up?
Thanks, Dave. Amy, this was fantastic. Thank you so much for presenting it. And just to sort of piggyback to the rich infrastructure at Cincinnati Children's, the question I have is, let's say, like, you know, ideal situation, you could do the COM tool and the APPs who lead the code in the CICU. Something which I know CICU does at Cincinnati is the cardiac arrest prevention plan for PC4. How would you, like, would that be a confounding variable for the performance of the person? Like, let's say somebody who's been part of the CAP that day, and then, you know, that patient has a code and comes in and is the code leader. Have you thought about that aspect? Because the other aspect of this is, I know the PICU at Cincinnati, because Maya Divan presents at PD Rescue all the time, does the puddles, right? So, and you're in this situation awareness, and then that patient has a cardiac arrest. Like, would that have an advantage to the performance of the team leader if that team leader has been part of the puddle? Because, like, you know, there have been very specific tasks which have been discussed. For example, the epi spritzer, or having the Zoll at the bedside, you know, things like that. Have you thought about that?
I have. I actually co-lead the cardiac arrest prevention here at Cincinnati, and was one of the national nurse leaders for the PC4 QI project as well. So I'm very familiar with CAP, and I work closely with the PICU and the NICU for their adaptations of CAP as well. So for those of you guys not familiar, CAP, or cardiac arrest prevention, was a QI initiative through the Pediatric Cardiac Critical Care Consortium, or PC4, where we looked at implementing improved situational awareness through this cardiac arrest prevention program. And so PC4 was able to use their metadata to analyze what patients were most high risk across all institutions for cardiac arrest. And there were 3 indicators specifically that were inclusion criteria. And then there was like an other that centers could add their center specific criteria. And they implemented these this CAP bundle, which was a safety huddle where as a team with all providers involved in these high-risk patients, you talk about their clinical deterioration, what those signs and symptoms would look like, what your mitigation plan would be if they have these signs and symptoms. And so for instance, for our neonatal status post bypass patients in the CICU, we have we call it like a hypovolemia, where your systolic blood pressure is less than blank and your CVP is less than blank, then you give a 5 per kilo fluid bolus. If your systolic blood pressure is less than blank and your CVP is greater than blank, then you increase your epi drip or your vaso drip by whatever. And it's all like fill in the blank, so you can make it very prescriptive for individual patients. It looks like Pooja added the link to the publication. Thank you. And then there's like a emergency, like if the heart rate's less than 100, give an epi spritzer. If the heart rate is less than 60 or you lose pulsatility, then you start CPR and give a code dose epi. So it's really prescriptive, and different institutions have used it differently. At our institution, we actually allow our nurses to fully enact the plan without a provider at bedside. So if the code bell goes off, my nurse has probably already given an epi spritzer as the patient decompensated. If they get to a full blown code, the CPR has already been started and a code dose of epi may be in before a provider gets to the bedside. This is, if you look at the publication across all the PC4 centers, there were equal number of control and intervention groups, and the intervention groups reduced cardiac arrest by 30%. And those in the control group saw no difference in cardiac arrest. So if anyone is interested in learning more about that, I know about it as well. But to answer the question now that I've given the background, it really doesn't change anything from a leadership standpoint, because the things that make someone a good leader are the same, whether the patient is having like a slow patient decompensation event, whether the patient is having a rapid decompensation event. You just don't have to be the one to verbally say, like, give the dose of epi. And so to me, saying give the dose of epi is important as a team leader if it's not happening, but in a team that already knows what to do, it's still those other leadership behaviors. So thinking about an exit strategy, making sure you're appropriately managing your team. If the patient is, like having a pulmonary hemorrhage, is everyone looking at the pulmonary hemorrhage and no one is like focusing that the patient is also having an arrhythmia and missing it. So having that team leadership where you make sure you are like focusing on the appropriate task, but keeping a broad picture of what's going on, verbalizing your shared mental model, thinking about your differentials, your exit strategy, things like that. So I would say that having something like the CAP program, whether it's in the PICU or CICU, NICU, or, we have watchers on our non-critical care areas, it certainly has improved situational awareness so that the people arriving when the code bell goes off have a better idea of like what to expect when they walk in the room and what interventions might actually happen. But the leadership component of it, to me, isn't changed.
Thank you. And thanks everyone for the great questions. It's now the top of the hour. So I would like to thank Amy sincerely for that presentation. It was wonderful. It generated a lot of interest and comments and questions, which is exactly what we're looking for. So thank you again for coming here today and discussing your use of the COM tool. At this time, we will transition into small groups for the next 20 minutes or so to continue this discussion. And Amy, it's up to you, but if you are okay with it, if you wouldn't mind putting your email or some contact information in the chat, and just in case anyone has any direct questions for you in the future, or potentially from anyone who might be watching this, not at this time, but on a future recording, that would be helpful as well. And at this time, we'll break into 3 small groups to continue this discussion. And Leah Bozeman has already added people to the different rooms. So just click join on your screen and we'll see you in the smaller rooms. Thanks, everyone. For those of us who are able to stay for the whole time, we really appreciate you joining us today for a great conversation. Looks like it's cold there, Shannon. Hey, Shannon. But everyone, thank you for joining today. Amy, that was a wonderful presentation again. Really learned a lot about this tool, learned about validity assessment and some of the difficulties with that, but also some of the benefits that you've been able to look into and how you've been using it. And it generated some wonderful discussion, both in the large group. We had probably 20 or 30 minutes of questions, which is a new record here. And then also continuing that conversation in the small group. So thanks again, everyone, for joining us today for our Inspire Grand Rounds. We really appreciate having you here with us. And thank you again, Amy Flores, for her presentation.